Hello, everyone. Today's topic is cancer-related fatigue. These are the objectives of the presentation. By definition, cancer-related fatigue is a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that's not proportional to recent activity and interferes with usual function. Clinical fatigue. In contrast to muscle fatigue, clinical fatigue is a multi-dimensional phenomenon and includes three major components. Number one, generalized weakness, resulting in inability to initiate certain activities. Number two, easy fatigability and reduced capacity to maintain performance. And number three is mental fatigue, resulting in impaired concentration, loss of memory, and emotional lability. Fatigue prevalence. Fatigue is reported as prevalent in most studied populations, including patients with cancer and palliative care patients. The frequency of fatigue has been reported to be approximately 60 to 90% in patients with advanced cancer, whereas prevalence of fatigue is around 20 to 30% in cancer survivors. Impact of fatigue. Moderate to severe persistent fatigue affects the patient quality of life and ability to perform activities that add meaning to their life. Fatigue has been associated with other symptoms such as pain, anxiety, depression, cachexia, and insomnia. However, assessment and treatment of this common symptom is difficult as it is a complex subjective symptom and is often underreported. This is basically some of the generators or triggers of fatigue. As you see, multiple generators, such as cachexia, mood disorders, inflammation, drugs, including opioids, cancer-related symptoms, anemia, tumor byproducts, infection, dehydration, bioimmunotherapy, chemotherapy, radiotherapy, renal, hepatic, or heart disease, and lastly, deconditioning. Tumor host-derived factors and cytokines. The current growing literature is increasingly supporting the prevailing hypothesis that the presence of a tumor and/or cancer-related treatment, such as chemotherapy or radiotherapy, induces dysregulation of pro-inflammatory cytokines, such as tumor necrosis alpha, interleukin 1 and 6. Furthermore, cytokines have been implicated in the pathophysiology of fatigue by acting on multiple systems, including the hypothalamic pituitary adrenal axis, psychological and dopaminergic alterations, and sleep, immune system, and muscles. So to wrap this up, it's the same like we talked about cachexia, and you will see eventually that there's a correlation between cachexia and fatigue. So the two main pathophysiologic mechanisms underlying fatigue are inflammation and metabolic derangements. Okay, same like we've seen with cachexia anorexia syndrome. And this adds to the complexity of the problem. Muscle abnormalities. Impaired muscle function may be a potential major underlying mechanism of fatigue, and this is partially related to cytokine production. In cancer patients, myopathies also can be induced by medications, such as cyclosporin, which has been implicated as a cause of mitochondrial myopathy, and corticosteroids can cause loss of muscle mass. Mitochondrial enzymes. Of the mitochondrial enzymes reviewed, only plasma Q10, coenzyme Q10 levels were found to be significantly and consistently inversely correlated with fatigue expression. So patients that has low coenzyme Q10, they have fatigue. Deconditioning, prolonged bed rest and immobility lead to loss of muscle mass and reduced cardiac output. Deconditioning results in worsened muscle mass, which may be compounded by other muscle abnormalities in patients with cancer. Central nervous system abnormalities. Primary or secondary tumors involving the CNS and subsequent invasion of the brain tissue, particularly the pituitary gland, appear to be possible causes of fatigue in cancer patients. Brain tumors can cause cognitive dysfunction, and other tumors, such as small lung cancer, can also affect the brain function by production of neurotransmitters or hormones. Antineoplastic treatments such as radiotherapy, chemotherapy, and medications used to treat complications of cancer, such as corticosteroids and opioids, can also impact the CNS. Relation between fatigue and cachexia. Fatigue and cachexia coexist in the great majority of advanced stage cancer patients, and it's likely that malnutrition is a major contributor to fatigue. The resulting loss of mass from progressive cachexia can cause profound weakness and fatigue. As you see in this picture, this is the CEO of Apple, Steve Jobs. He had cachexia, anorexia syndrome, and fatigue. He had pancreatic cancer, and as you can see, he lost a lot of weight. Infection. Fatigue is frequently associated with infections, particularly those that are recurrent or protracted. It may occur as a prodrome, and it might outlast the infection by weeks or even months. Anemia is prevalent in cancer patients. Common causes of anemia in cancer patients are myelosuppression by chemotherapeutic agents, iron deficiency, bleeding, hemolysis, nutritional deficiencies, and anemia owing to chronic disease. Severe anemia, hemoglobin below 8, is known to be a cause of profound fatigue. In patients receiving chemotherapy, treating less severe anemia has been shown to improve energy levels, activity levels, and quality of life. Autonomic dysfunction is a common complication of advanced stage cancer This syndrome includes malnutrition, delayed gastric emptying, chronic nausea, anorexia, and poor performance status. Postural hypotension has been documented in patients with specific type of severe chronic fatigue syndrome. The association between fatigue and autonomic dysfunction has not been established in cancer patients and should be investigated in the future research. Neurological disorders. A number of neurological disorders are associated with fatigue, some of which may be the primary disease, such as amyotrophic lateral sclerosis, myasthenia, Parkinson's disease, multiple sclerosis, and other demyelinating diseases. On the other hand, some neurological disorders occur as a result of a terminal disease and may sometimes precede the disease by quite a long time, such as paraneoplastic syndrome, Eaton-Lambert syndrome, and dermatomyositis slash polymyositis. Treatment here is a disease specific. Though most of these diseases are progressive despite treatment, and both the disease and associated fatigue become irreversible, at which point symptomatic therapies, both pharmacological and non-pharmacological, are introduced. Psychological issues, anxiety, depression, and psychological distress may contribute to fatigue. However, the nature of these relationships is unclear. The diagnosis of a major depressive episode in patients with advanced stage cancer is difficult because of the patients frequently present with neurovegetative and somatic symptoms that are part of the disease itself. Nevertheless, cancer patients presenting with an adjustment disorder or major depressive disorder can have fatigue as one of the prevalent symptoms. Metabolic and endocrine disorders. Endocrine disorders such as diabetes, Addison disease, and hypothyroidism, or electrolyte imbalance such as hyponatremia, hypokalemia, and hypercalcemia are possible causes of fatigue and in many instances have relatively simple and effective treatments. Testosterone deficiency results in a loss of muscle mass, fatigue, reduced libido, and reduced hemoglobin. Androgen insufficiency in cancer patients can result from cachexia anorexia syndrome. In addition, chemotherapy and radiotherapy can cause hypogonadism. Hormonal ablative therapy has been found to significantly increase the incidence of fatigue in patients with prostate cancer. In patients with testosterone insufficiency, treatment with androgenic anabolic steroids, including testosterone and its derivatives, has been found to increase the muscle mass, improve muscle energy and libido, and increase hemoglobin levels. Androgenic anabolic steroids are regularly used in treatment of hypogonadism in HIV patients. Continue metabolic and endocrine disorders, abnormalities of the hypophyseal pituitary axis concerning corticotropin releasing factors have been postulated as another possible endocrine-related cause of fatigue. The pro-inflammatory cytokines such as interleukin 1, 6, and tumor necrosis factor are central mediators of the inflammatory process that can result in the dysregulation of the hypophyseal hypothalamic pituitary axis, and the secretion of mediators that induce such symptoms as pain, fatigue, anxiety, and depression, leading to impaired quality of life. Opioid-induced hypogonadotropic hypogonadism can basically manifest as fatigue, depression, anemia, reduced libido, erectile dysfunction, and osteopenia. Symptoms improve with androgen therapy, occurs more frequently with sustained release or methadone in a setting of chronic opioid therapy. So when I have a patient on high dose opioids for long term, I check serum testosterone, both total and free testosterone, and I replace the patient if there is no contraindication for testosterone. Side effects of cancer treatment can lead to fatigue, such as chemotherapy and radiation therapy. For example, radiotherapy can lead to anemia, diarrhea, and anorexia. And chemotherapy causes anorexia, nausea, vomit, and anemia. All of these factors can contribute to fatigue. Side effects of cancer treatments, such as biological response modifying agents, has been also implicated in fatigue. For instance, interferon alpha was shown to cause fatigue in 70% of patients. In fact, fatigue is the most frequent dose-limiting side effects in patients receiving biological response modifying treatments for cancer. Chronic hypoxia. The association here with fatigue is probably best studied in chronic airway disease, where oxygen therapy has been shown to improve quality of life in patients with fatigue as one of the symptoms. Common symptoms of cancer-related fatigue: physical fatigue, stress, attention deficit, mental fatigue, nausea, short-term memory loss, physical pain, and lack of concentration. Assessment of fatigue. At a clinical level, we use the Edmonton Symptom Assessment Scale developed by Dr. Barrera. Fatigue item, which evaluates the average severity of the fatigue in the last 24 hours. And it's basically in a scale from 0 to 10, where 0 is no fatigue and 10 is the worst fatigue. Functional assessment of cancer illness therapy, FACIT-F subscale. And there's another one called Patient-Reported Outcomes Measurement Information System, PROMIS. And there's item bank fatigue shortfall. You don't have to memorize these, but these are basically research tools to assess fatigue. The one that we use in the clinical setting is the ESAS, or Edmonton Symptom Assessment Scale, which is really pretty straightforward scale. Assessment of fatigue in clinical practice, as I said, it depends mainly on the ESAS. And the other ones, the FACIT-F and the PROMIS SF, are basically ones used for research. I'm not going to go through these scales, but just remember the names in case you're planning to do some research on cancer-related fatigue here. All right. So these are the tools that you need to use. This is the facet, and this one, the ESAS. This is the one that we use in clinical setting. All right. And I'm sure all of you guys are aware about it as a palliative physicians. And this one is Promise Item Bank, short form. Fatigue can be managed symptomatically, or you can work on the underlying causes. And the right way to do it is to do both. So if you have cachexia, anemia, infection, hypogonadism, pain, hypoxia, deconditioning, or others, you need to treat it as much as you can, of course. As far as symptomatic management, there are non-pharmacologic and pharmacological. Non-pharmacological is counseling, physical therapy, occupational therapy, and exercise. I will put I put stress on this one here in particular, exercise. Pharmacologic, short course of steroids, and then we have emerging drugs, trial of psychostimulants, ginseng and fish oil. Pharmacologic, established agents like corticosteroid, megasterol acetate, psychostimulants such as methylphenidate and modafinil, testosterone. Emerging agents, agents that inhibit the cytokine action, such as thalidomide, COX-1 and 2 inhibitors, omega-3 fatty acids, a melanocyte-stimulating hormone, agents that block the cytokine release, such as pentoxyphylline, bradykinin antagonists, donepezil, drug used in dementia, monoclonal antibodies, such as infliximab and L-carnitine. Corticosteroids are presumed to decrease fatigue by their effect on the inflammatory cytokines, IL-1, IL-6, and tumor necrosis factor. And also, it has an effect on the hypothalamic pituitary axis. Studies have been done on steroids, dexamethasone and methylprednisone have been shown to improve fatigue, appetite, and sense of well-being. There was, however, no associated weight gain or improvement in the performance status. It has other beneficial effects on nausea, appetite, and pain. Megasterol or progestational steroids. These are also drugs that has been used in fatigue, and the mechanism really is unclear of megasterol acetate. All right. The main issue with megasterol acetate is it increases the risk of thromboembolic events. So you have to be super careful with patients that has a history of DVT, for example. Besides, it can cause adrenal suppression and insufficiency upon abrupt discontinuation, hypotension, hyperglycemia, increased risk of breakthrough uterine bleeding, and skin photosensitivity. Dexamethasone, megasterol. These are the two commonest agents we use. But the dose here is not 40 milligrams. We use up to from 160 to 400 milligrams a day. This dose here, we use it, the 40 milligram per ml is only used for something like hot flashes. Psychostimulants like methylphenidate, all right, this is a very important drug, especially if the fatigue is related to opioids and sedation from opioids. We have also other psychostimulants such as modafinil and amantadine. Modafinil is a psychostimulant, is effective and well tolerated for treatment of excessive daytime sleepiness in patients with narcolepsy and conditions such as Parkinson's disease and obstructive sleep apnea. It was studied in HIV positive patients and also in ALS patients and was found to improve symptoms of fatigue, depression, and sleepiness. Methylphenidate. The usual dose is around 10 to 20 milligrams per day. And the dose of modafinil somewhere between 100 to 200 milligrams a day. Extended release bupropion. This is only one study, but seems like promising results from using extended release bupropion. And the dose they gave to their patients is around 150 milligrams. I had a case like this, and the patient responded very well to extended release bupropion. I cannot tell you that I have extensive experience with it. It's only one patient, and he was taking the medication before he showed up to me. And he said that this medicine is helping him a lot, so I continued the drug. And I found that also that he did not respond well to the short-acting form of bupropion. He responded only to the extended release. Testosterone. Low testosterone is common in patients with advanced cancer. Low testosterone has been associated with high inflammatory markers and high symptom burden in patients with advanced cancer. Treatment with testosterone replacement has been beneficial in the management of symptoms in cancer in non-cancer patients. The use of testosterone and its derivatives and other androgenic anabolic steroids have been shown predominantly in patients with hypogonadism due to HIV disease to increase the muscle mass, improve energy and libido, and increase the hemoglobin levels. So again, to wrap this up, testosterone is important hormone in cachexia anorexia syndrome and cancer-related fatigue. And it is present especially in patients with advanced cancer, also patients, of course, getting hormonal therapies that can lower the testosterone, HIV patients, and patients on long-term high-dose opioids. All of these guys can develop low testosterone. You need to check their total and free testosterone and replace, with testosterone injections if there is no contraindication. Sometimes you have to talk to your oncologist about that, especially if the oncologist is giving, giving hormonal therapy, like patients that has prostate cancer, for example. Testosterone, the usual dose is 200 milligram on monthly basis, sometimes every 2 weeks. Midodrine. Midodrine is a blood pressure medication that elevates the blood pressure related to autonomic failure. Midodrine is a specific alpha-1 sympathomimetic agent and has been used to manage autonomic failure in other conditions, such as diabetes, and might have a therapeutic role in autonomic failure in the palliative care population. All of you guys are aware about midodrine. So this is extremely useful, especially patients that develop postural hypotension and has autonomic failure related to diabetes or other neurologic disorder. Anemia treatment. So unfortunately, treatment of anemia advanced cancer has not been studied in a randomized controlled trials. The mainstay of treatment for anemia in palliative setting are blood transfusion and synthetic erythropoietin, or EPO, for to make it shorter and easier to pronounce. The EPO and darbepoetin are synthetic drugs administered subcutaneously, either weekly or every 3 weeks. Several trials in the past have shown the benefit of EPO with respect to decrease in the need of red blood cell transfusions and improved quality of life and hemoglobin levels. Blood transfusion. In a Cochrane review by Preston et al., the effect of blood transfusion for treating anemia in patients with advanced cancer was analyzed. 12 studies with 653 participants were identified, and the primary outcome in 5 studies was improvement of fatigue for 2 to 7 days, with the effect waning after 14. And this is exactly what we've been doing in the clinical setting here. Patients, with severe fatigue, we used to bring them as outpatient and give them blood transfusion, 1 to 2 units maximum, every 2 weeks. And the reason or the rationale is for palliation, not to treat the anemia. Okay, it's to treat the effects of the anemia. EPO, blood transfusion. Okay, other things that we can try in fatigue is omega-3 fatty acids. As you see, omega-3 fatty acid is present in salmon, almonds, olive oil, and so forth. Omega-3 fatty acid or fish oil. Okay, as you see from this picture, that good nutritional status, a good uptake of omega-3 fatty acids from fish oil supplements can lead to reduced cancer-related fatigue. You don't have to take it as capsules if you want, but you can take it in your food. Non-pharmacological management. We have basically a mnemonic for this. Prioritize, plan, pace, posture, permission. So I want to explain one thing here is pacing. I mean, with pacing, it means that, when you're walking, you need to start to take some regular breaks. Do not overdo it. so you can actually keep moving as much as you can. Graded exercise therapy. In general, exercise should be prescribed for patients with advanced stage cancer if appropriate, as exercise may be beneficial to maintain the muscle mass and physical strength, which are commonly affected due to cachexia and related progressive cancer. Increase in physical activity may further be beneficial in improving outcomes, including maintaining independence, self reported physical functioning, well being, and self esteem and energy. Physical exercise is useful, especially in cases of deconditioning. The physiotherapist can suggest suitable exercises and encourage increased activity, which might have a beneficial effects from both physical and psychosocial perspectives. In addition, if the patient is immobile, a physiotherapist can perform passive movements that can help the patient maintain flexibility and decrease painful tendon retraction. Light therapy has been shown to have a strong effect on sleep and circadian rhythm in other medical conditions, but its effects on cancer related fatigue are largely unknown. Preliminary studies in breast cancer patients have suggested that bright white light prevented cancer related fatigue from worsening during chemotherapy when compared to dim red light. Bright white light therapy. CAM therapy. Several studies have been conducted using acupuncture as intervention for cancer-related fatigue. Um, and with this, intervention, it showed that it improved all fatigue aspects, including physical fatigue and mental fatigue. Other studies have shown that massage, qigong, and tai chi has been, used in treatment of cancer-related fatigue with a positive effect. Some acupuncture points like pericardial 6, large intestine 4 for fatigue, or kidney 1, spleen 6, Tai Chi, chair yoga. I love this one. We used to do it in our institution. It's super simple, and anyone can learn it and teach it. And the patients really, they feel good after, their yoga. Herbal medications. The most important one is the American ginseng and also the ginkgo biloba, coenzyme Q10. Remember, this is a mitochondrial enzyme. Acetyl L-carnitine. Cognitive behavior therapy. Long-term oxygen therapy has been shown to help with fatigue. We call it LTOT. It increases survival, improves quality of life of hypoxemic patients with COPD. Key learning points: cancer-related fatigue is defined as a distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion related to cancer or cancer treatment. It's not not proportional to risk of function. Fatigue is a complex, subjective, chronic, multifactorial, and multidimensional symptom. Therefore, a systematic evaluation. Fatigue assessment characterizing its severity, several features, rating, and related factors, associated risk, and impact on daily life, and identifying treatable causes. Management of fatigue includes both non-pharmacologic and pharmacological therapy. Thank you.